the WA team to just give an acknowledgement of lived experience. So thank you, Trish.
Hi, I'm Trish. I think it's funny that in the first session everyone was at the front and then now everyone's gone to the back. Hi, Zoom people as well. So my name's Trish Owen. This is my third week at Shelter as the project officer for the Home Lived Experience project. So we're really excited to have an avenue to advance the voices of those with lived experience of homelessness and housing insecurity. I want to do this acknowledgement. Thank you, Anthea. She's gone maybe, but for sharing your lived experience, she's speaking, of homelessness. And for those that heard that, you would have felt the emotional weight that came with a story like that. And this is why we've got this specific projects to make sure that we can upskill and educate people about how to do that well. And I just want to acknowledge that those with a living experience of homelessness, some who are in the room, Deb, Josh, Al, and those that aren't here and those that have gone before us to advance the voices of those with lived experience. This is not easy work, and I just want to pay my respects to those people, especially those the First Nations people who are disproportionately represented in the cohort of people experiencing homelessness. So just want to keep people with a living experience explicitly at the forefront of our mind, because that's why we do the work that we do. Thank you.
Thank you, Trish. And on Wednesday's program, Trish and Elise will be outlining more about this fantastic new project that's been funded through the Sisters of St John of God. It's a 3-year program to really accelerate a lived experience advisory council, which will be spun off out of Shelter and really provide a voice for people with lived experience to participate in policy and advocacy work, along with a number of other projects. Thank you. So in terms of this session's program, we know that the pandemic raised significant legacy issues across all social determinants of health, with homelessness presenting unique public health challenges in WA and across the globe. So we are thrilled that we'll be hearing from Lydia Stazen, the Director from the Institute of Global Homelessness via Zoom. So Lydia will be joining us, and this will be followed by a panel session with the very fantastic CEO of Indigo Junction, Sharon Gough, and Homeless Health Service Manager at St Vincent's Hospital in Sydney, Matt Larkin. Unfortunately, there's been a late change in the program. Our guest is Dr. Revel Bangor-Jones, the Incident Controller and Human Security Officer at the State Health Incident Coordination Centre, fondly known as SHIC, and Natalia Gemmell, the Director of Emergency Services at the State Welfare Incident Coordination Centre at the Department of Communities, known as SWIC, and Dr. Amanda Stafford, the Consultant and Emergency Department Clinical Lead for the Royal Perth Homeless team at Royal Perth Hospital, are unable to be here today. Many of you would be aware that SHIC work closely with the homeless sector and SWIC and other agencies and stakeholders to respond to the challenges of COVID. Significant progress was made in supporting the sector during this period in response to sector concerns, and work continues to build on the progress to date. And while there were some challenges, there were some great outcomes that were collectively progressed. And I was speaking with Deborah Zanella this morning, and one of the key challenges was the disconnect with health and the homelessness system, and the challenges of health working with our sector with a group of highly vulnerable people who had no home. So we've been advised by SHIC and SWIC and the Department of Communities that there's a lessons learned from the response of COVID being reviewed, and a scope of work in development to ensure that this is a comprehensive response. And a dedicated review of the COVID response to homelessness will form part of that process. And Community's intention is to provide an opportunity for the sector to contribute to the lessons learned process. And once that's been finalised, an information session will be conducted with the sector to discuss findings from the process. So I think we jumped the gun by inviting them along, and they weren't quite ready to participate today. But I just want to share that I've always been able to pick up the phone to SWIC and SHIC. I had Revel and Natalia at the end. They always answered. They were really swift, and they worked and tried their best when things were tough to really support the sector deliver the outcomes at the time. And if I reflect on the last 2 years, it's the sector that works so well together. And to quote Deborah Zanella, they were at their collaborative best. So it's been an extraordinary 2 years, and moving forward, we look forward to working with our government partners on the lessons learnt process, and Shelter's role will be to make sure that we're all engaged in that and we can have a really thorough forensic examination of what worked, what didn't work. So if there were another pandemic, God forbid, we'd be in a much, much better place for people experiencing homelessness. So I would now like to introduce Lydia Stazen, the Director of the Institute of Global Homelessness. So immediately prior to joining the Institute for Global Homelessness, Lydia served as Vice Chancellor of Advancement and President of the City Colleges of the Chicago Foundation, where key achievements included establishing a $500,000 fund for student basic needs emergencies and securing funding for a full-time position to drive a college-wide response for students experiencing homelessness. You don't often think about that, so it's pretty magnificent. Lydia also served for several years as Vice President of All Chicago Making Homelessness History, where she was instrumental in integrating homeless data with medical data to help patients experiencing homelessness access housing services. Lydia was a Greater Good Fellow at Northwestern University's Kellogg School of Management in 2015 and has been a featured panellist at the Association for Fundraising Professionals Midwest Conference. So can you please join with me in welcoming Lydia? Thank you.
Well, hello from Sunday evening in Chicago. I definitely wish I could be with you there in person, but I am really grateful for the technology that allows us to connect across thousands of miles and time zones. And so it still is really a gift for me to be with you virtually, your morning, my evening. And so thank you very much for inviting me today. So I really very much appreciate how in Australia you begin all of your meetings by acknowledging, the Indigenous lands and the traditional custodians. So here in Chicago, I'm on the land of the Council of the Three Fires, which was an alliance of three different tribes, the Ojibwe, the Ottawa, and the Potawatomi. And I love that the history of these lands are of different tribes coming together to establish trade agreements, to understand how they could work together and partner together to make things stronger for the region. And I think there's so much wisdom in those approaches that we can take when we think about addressing homelessness. So we're headquartered on these lands, but IGH's work on homelessness is global. So I'm going to try to share my screen. I've got a bit of a presentation to run through with you, but I'm going to share a little bit about the work that IGH does, and then talk about some of the findings on homelessness and health that came from our recent research project on the cities where we work, particularly in the light of COVID-19. So that's how I will be structuring my comments this evening. Okay, so you all should be able to see that now. So this is just a quick overview of IGH's three strategic priorities. We use the tagline, see it, solve it, share it, to describe what we do. The first category, see it, is really kind of describes our work with the United Nations, where we are advocating for some international homelessness policy that's focused on definitions of homelessness. So what is homelessness globally? What is the problem that we're trying to solve together? And then right along the heels of that is measurement. What is the scope of the problem that we're trying to solve? Those are two really important building blocks that we're advocating for, because right on the heels of that can come more specific interventions on homelessness. So that's our first area of work. Our second area of work is where we partner with cities and also countries who are really ready to take some concrete action to end homelessness. Here's a bit of a slide that shows you all of the communities where IGH works. So starting in North America, we have Edmonton. In Canada, we have Chicago, as well as Little Rock, which is a smaller city in a southern part of the United States. Moving down into South America, we work in Montevideo, Uruguay, as well as Santiago, Chile. Moving across to Africa, we work in Shwane, South Africa. Up to India, we work in Bengaluru, India. In Australia, we partner with Sydney and with Adelaide. And then moving up into Europe, we work in Rijeka, Croatia, Brussels, Belgium, Glasgow, Scotland, and Greater Manchester in the United Kingdom. So you can see just a really diverse set of cities. And then finally, our last area of work is share it. So what is working? Where is it working? Why is it working? What's not working? Because we also believe we can learn as much from failure as we do from success. And so, really just sharing what we're learning with ever expanding kind of circles of folks who care about these issues in the same way that we do. So what I'm going to do next is to drill down more into that solve it category, as we've just completed an independent evaluation of the program that we've kind of deployed in these cities. And so the research team was led by Suzanne Fitzpatrick and Volker Busch-Geertsma from both Heriot-Watt University and GISS in Bremen, Germany. And so the research team really delved deeply into all the aspects of homelessness in this incredible diverse set of cities where IGH works. And so, when the pandemic broke, we realized we had already kind of started this research project, but we realized it was a really great opportunity to explore how different communities were addressing something none of us had ever addressed before, a global pandemic. And so I'll be sharing these health-related findings with you today, and then offering some reflections for concrete actions that are kind of particular to your context there in WA. So the first one really key finding that the research team surfaced was lack of access to mental health services and substance use services. When we think about health, it's important, that we not just think about the physical health aspects of it, but also the mental health aspects. And so I put up a couple of really kind of interesting quotes, I think, from the people who participated in the research. So great quote from Adelaide there, talking about how difficult it is for people who have chronic health issues, chronic mental health issues, complex issues, connecting into the environments and being treated and then released. Similar situation happening in Rijeka, Croatia. They often cannot address a situation until someone is hospitalized in the psychiatric ward. Again, we found in Montevideo, which again is in Uruguay, that there's really a lack of resources and discrimination from the healthcare workers towards particularly the street homeless population. So, and this is true for both physical health and for mental health as well, really, dismissive attitudes, not being able to kind of receive the dignified care that they deserve. One really interesting piece that came out of the research in Edmonton was the impact on staff as a result of the kind of lack of access to the mental health services and substance use services. So, really recognizing that these are incredibly complex jobs that the staff are doing, and kind of surface that nuance that, can be very young and inexperienced people working in some of these jobs because of the pay rate that the staff are offered. And so some of the impacts on the staff there was something that came through very strongly, particularly in Edmonton. So when it comes to COVID-19 and this issue, we really saw a mix across the city. So in some cities, COVID-19 helped to increase access to mental health services. So here in the United States, we have a very complex health insurance kind of framework we're working in, and the telehealth rules changed drastically for the better. Telehealth is not something that was widely accessible in the United States before the pandemic, and that really changed. And in some communities like Little Rock allowed for more people to access health in that really flexible way. In Glasgow, they took the opportunity to really reconfigure the entire way that the homeless health services were delivered in a way that was very positive and again increased access. In Tshwane, South Africa, they really found that many more people who were homeless were aware of the drug treatment services that were offered. They were able to offer those more and more as people learned about them. And they saw people accessing and taking them up on those offers of services. Also, previous to the pandemic, they had very strict rules around their shelters that anyone who was using drugs was not allowed to go into the shelters. And again, the pandemic allowed some opportunity to change how that was operating in a way that allowed them to better serve people who were, experiencing homelessness. So a couple of interesting things there. So some other impacts of the COVID-19 pandemic we saw on sort of the health and the service delivery. We saw more self-contained accommodation. A lot of that was, creative uses of empty hotel rooms or different types of accommodation, but more self-contained. We saw less communal accommodation. So as communities move towards self-contained accommodation, they maybe decompress some of the shelters or just reduce the amount of communal accommodation that had previously been on offer in those communities. Expansion of temporary accommodation. We saw increases in national and local funding in most of the communities where we work. We saw better coordination between homeless services and the healthcare sector. That was a finding that was true across all 13 of IGH's Vanguard cities, that there was better coordination between the homelessness sector and the health sector before, lots of silos happening. And so again, a real opportunity for these two different sectors to come together. We saw far more inclusive and less conditional approaches, I would say. So for example, in the United Kingdom, the issue of migrants and homelessness is a very complex one. Most migrants in the United Kingdom are not eligible for public funding and some of the welfare services that are offered to people who are citizens. But we saw those restrictions flex during the pandemic, so that people who are migrants can also access some of the homeless services and the housing. Also documentation. So here in Chicago, one of the strategies that was deployed was called the Expedited Housing Initiative. And one of the things that they kind of essentially waived as a part of that process was, prior to the pandemic in Chicago, before you were going to receive your accommodation, you had to have all your documentation in order. And during the pandemic, they said, you know what, let's put people in houses. We'll figure out the documentation on the back end. If something needs to change, if a person needs to be moved for whatever reason, we'll figure it out after the fact. And that really took away a barrier. And it allowed people to move much more quickly into the accommodation that was available. So lots of positive things to kind of surface in terms of how homelessness was addressed during the pandemic. Again, just wanted to share with you a couple of really interesting quotes that came out from the different interviews. So Edmonton kind of underscoring the dignity of the offer of self-contained accommodation. I think that idea that it's a show of good faith that can connect, the service providers with the people experiencing homelessness and understanding that, things can start happening very quickly, move in quickly. I think that's the ideal that we should all be pushing towards, is like, what is our offer to people who are experiencing homelessness? How quickly can we make it happen for them? And so that, again, that dignity of being able to move into self-contained accommodation where you have your own bathroom, you have your own shower, you can take a minute to yourself. In Santiago and Montevideo, they had really large shelters prior to the pandemic. So shelters that could serve a maximum of 500 people. So just massive shelters. They decompressed all of those shelters and they set up many different smaller shelters. So they've really moved away from these massive shelters to serving smaller numbers of people. And the staff were surfacing how, it allows them to just create better atmospheres in those smaller shelters. The care teams can provide much better services to 20 people because they know them, they can get to know them, they can have time for conversation with them and connecting them to different types of services. And so they really felt that was definitely a positive move for them and an opportunity to restructure how the shelter services were delivered. We also are really proud of our colleagues in Bengaluru. They were not able to really decompress their shelters, and so they focused very, very much on, protective measures, making sure that there was as much personal protective equipment as possible for people in the shelters. They brought in and did daily yoga in the shelters with people who were living there, and they lost 0 lives during the pandemic to COVID-19 in their shelter population. So a really wonderful, wonderful outcome there. We saw in 4 communities, 2 of which are there in Australia, really great progress in terms of temporarily reducing street homelessness. So in Glasgow and Greater Manchester in the UK and in Adelaide and Sydney, we saw homelessness being really radically reduced, even virtually eliminated. This was through kind of the everyone in campaigns in the early days of the pandemic, making use again of these, empty hotel rooms, other forms of self-contained emergency accommodation. So if you think back to those early days, 2.5 years ago, just that push to get everyone in off the street. We weren't quite sure what this virus was. We knew it was dangerous and had the potential to be very dangerous for people experiencing homelessness and living in these communal shelters. We felt that urgency, we felt that political will, and in 4 out of our 13 communities, that was what we saw. In the United Kingdom, they also used this time period to do really full health assessments on people who were in the self-contained units in the hotels, to provide, basic foot care, dental care, get hepatitis vaccines, meningitis vaccines, those types of things, really to make sure that anyone who had been brought in, even if they ended up back on the street in the future, would be sort of better off from a healthcare perspective. And so that was another aspect of what happened there in the UK. We saw too in Glasgow, they have permanently ended their street homelessness as a result of the pandemic. When we heard that they had sort of temporarily ended it, I was as skeptical as anyone to say, can they do it? Can they continue to keep homelessness ended there in Glasgow? And they have. I talked with representatives from Glasgow last week, Thursday, and they had still just 5 people on the street. And those are 5, they have managed to stay right around 5. I think that would fit the sort of by name list definitions of functional 0. And so those 5 people kind of rotate. They'll get 5, those 5 off the street, and then, they haven't completely gotten their grip on prevention, although they're working towards that. And so some people still are becoming homeless, but they're able to very quickly build relationships with them, quickly bring them in, give them an offer of housing, and move on that way. So they really have ended homelessness there. And we're so proud of them and so glad that they were able to use this opportunity to do that and to keep it ended. So they have closed their last communal shelter. They have no more communal shelters there in Glasgow. And they've replaced it with the sort of self-contained temporary housing. So what they have now downtown, they have what they're calling a rapid rehousing welcome center. And so people can stay there overnight in a kind of ensuite room with a bathroom, and then in that welcome center are services delivered by a variety of agencies that are providing sort of housing, counseling and connection, healthcare services, other welfare and social services, and that's working really, really well there. really, really well there in Glasgow. So again, we're just really thrilled with their progress and their success and their continued success. And it will be really interesting to watch what really Glasgow and all of Scotland does next, because now that they have kind of eliminated that initial sort of street homelessness, they're really starting to think countrywide about what they're going to do about prevention. So again, kind of the immediate urgency of street homelessness has essentially ended, and they can start to think back upstream. Okay, how do we create some preventative measures that we can put into place to turn off the taps, as it were? So the other thing I wanted to share a little bit about tonight too was, the impacts of racism on homelessness and health. So just as homelessness is bad for one's health, so is racism. And we know that these two things are really deeply connected to homelessness. And the issues around Indigenous and Aboriginal homelessness in Canada and in Australia was surfaced pretty clearly through the research. And I say this with great humility as someone from the United States and someone whose country was founded on slavery. We have similar issues here with Black people who are African American are way overly represented in our homeless populations, and that's a result of the racist structures that we've created that have blocked them from housing and from the creation of wealth. And so this is not an issue that is particular to Australia. We see these impacts of racism on homelessness around the world. And so we need to recognize how our histories of colonialism have helped to create homelessness and figure out how we can dismantle some of those structures that we have inherited. And so, we know that homelessness responses have not been sufficiently sensitive to the needs of Indigenous people. And I know that you're thinking about that there in WA and taking some steps forward on that. So a couple of three really specific issues surfaced in the research in relation to this issue. So both overt and covert racism. In Edmonton, the folks that we interviewed there really talked about the blatant racism, especially from landlords, in not wanting to provide units for people experiencing homelessness who were also Indigenous. Lack of culturally appropriate housing stock came up in the different communities. And then really, I think this was particularly specific to the Australian context, but the different migratory patterns and needs that people who are Indigenous have. And there was a particular quote talking about this from, that's not the quote that I wanted. So I'll just kind of read it off my comments here. So that kind of the different migration patterns and the families moving from community to community was really particularly difficult during COVID, and helping communities to understand that we were all kind of on lockdown and under these different restrictions, and just got really, really tough and kind of limited some of the services that were able to be provided. And so really, again, here in Edmonton, talking about that systemic racism, and that even though there's an acknowledgement that this is present and this is impacting homelessness, really needing to move forward and take better actions on service plans, better actions on, delivering homeless services in culturally sensitive ways. We have acknowledged, we recognize the issues, time to continue to take steps forward in changing. Okay, I think that was the quote that I was looking for earlier when from a comment from one of the people that we interviewed there in Sydney, talking about the COVID-19 and how it was extremely difficult for particularly Indigenous people experiencing homelessness. So, okay, what do we do with all this information that I just threw at you there? So I think some of the things for you to think about in light of this global learning in this report, which is there's 123 pages of this report. So this is just a real quick highlight of some of the things we learned connected to the health related component of it. So definitely, if you are interested in reading more, it's all there on our website. But so some of the things that came out of this that I think communities need to be considering how to address. So first of all, from that first finding, really thinking about, okay, how can we invest in mental health and substance use services? Right along with that, how can we be better coordinated? So do we have coordinated discharge planning? Do we have integrated, multi-sectoral, multidiscipline care teams that are thinking about the different aspects of a person's health, from the physical to the mental, et cetera. I think, how do we train and support our frontline staff in the very complex jobs that they do and that they do so brilliantly, is something that has continued to come up during the pandemic, as everyone has been working on the brink of burnout now for really long extended periods. And we're seeing so much movement among frontline staff of, not even moving from different agency to different agency, but leaving the sector entirely. So how do we provide support to our frontline staff? How do we, for communities, and only Glasgow has really kind of carried the torch on this one, how do we return to the urgency and will that was there to temporarily end or make progress on street homelessness in particular during the pandemic? How do we get back to that? How do we continue to push that forward? Because we have learned so much. We saw what can be done. And how do we push that forward? And, there was so much talk about build back better. And I think in many ways communities have, but continuing to kind of hold that line there. How do we move away from communal shelters to more dignified offers of self-contained accommodation? I think the Rapid Rehousing Welcome Center that Glasgow established is working really brilliantly for them. I don't know that this would work in all communities, but Glasgow is not a massive city, so it has worked really well for them to be delivering those services right out of the downtown area. So thinking through, could that model be adapted for different communities in WA, I think is an interesting thought. And then again, finally, just really delving deeply into addressing the systems that have caused homelessness for Indigenous people. Again, I know you're committed to that, and continuing to push that forward will be absolutely critical to really ending homelessness there. So that is what I had put together to share with you tonight. You should know, IGH exists to support our communities in developing and implementing policies and programs. And so please just know that you do have a partner in us as you explore any and all of these thoughts. And so John and David both know how to get a hold of me, and so would be very, very happy to provide more information or share more on any of these points. So thank you very much again for having me.
Thank you, Lydia, and we really appreciate it's getting quite late over in Chicago, so Lydia's unable to keep joining us, but how great is that? Here we are in Perth, and we've just zoomed over to Chicago with an international expert providing her insights on global research to let us ponder what they've done around the world. It's pretty amazing. Another round of applause for Lydia. Thank you. So as I mentioned earlier, we've got a little program change. So we're going to see how we roll with this session. So I'd like to invite Sharon Gough to the stage. So Sharon, who's the CEO of Indigo Junction. Please, round of applause for Sharon. And we've got, so please take a seat. And we've got the Homeless Health Services Manager at St Vincent's Hospital in Sydney, Matt Larkin. So Matt's not joining us on the stage. Hopefully he's zooming in. Yep, which is fantastic. And as I mentioned, we've got apologies from Chic. last week and the homeless health team at Royal Perth Hospital. So we're going to change things up a little bit. And the plan for now is that I'm just going to ask Sharon, then Matt, to reflect on the impact of COVID on their services for a few minutes. In particular, what were the challenges, the opportunities, and if you had your time again, what would you do differently? So I'm going to sit down and join Sharon on the couch and channel my inner Ellen DeGeneres, but not all the bad parts of her. And this will be followed by a Q&A. So please, if you've got any questions, and because we have had some panelists leave the session, if there's anyone in the sector who'd just like to also share some insights, you're welcome to do that. So Sharon, CEO Indigo Junction, do you want to just paint a picture of Indigo Junction and where you are?
Fantastic. I feel like we've been abandoned here. The panel, the room is very strange. So Indigo Junction is a homelessness service provider. We're based in Midland. We've been there for over 40 years. And we run, I guess, a range of different services, but predominantly in relation to this session, we have 2 resource centres, and they support people sleeping rough in the local community. And unfortunately, Midland has got an increasing number of people, and predominantly families as well, but also kind of single and adult people sleeping rough. So in terms of COVID, and I guess just in preparation and kind of reflection around this session, I think initially we kind of started well back to the first kind of, lockdown period. And certainly Indigo is not a large organisation. We probably have 55 staff, so we're not, giant. We put a lot of kind of effort and energy. I think reflecting back to that time, there was a task force meeting every kind of second day in terms of mobilising the sector in partnership with health around what our response might be in terms of obviously supporting vulnerable people from the streets around prevention around COVID. I guess here we are in 2022, and to be honest, it felt quite chaotic in terms of the information coming from government and the lack of coordination. I think we touched on it earlier, just in terms of the gap between health and the sector in terms of mobilising that response. So for us, I guess we put a lot of energy and effort into it, and then at one point just decided we needed to step back and I guess just build and coordinate our own kind of course of action. So what we had done was I put a lot of work into prevention, and we worked with health, WA Police and our staff, but also people with lived experience around supporting, I guess, preparing the community for the outbreak. And through that, we were able to, I guess, employ people with lived experience that were part of our services. We had one community elder, and we also had a young person. So a lot of what the gap was, I think, was around, I guess, fear of vaccination and lack of access. So we were able to go out to people. I think there wasn't kind of one size that was fitting all, like in terms of people lining up at vaccination centres and being prepared for COVID to come. So what we did was basically provide an outreach service and went to people in terms of providing access. So we're able to, I guess, connect with over 800 people that probably wouldn't have sought vaccinations through that program.
So that's extraordinary. And one of the things that I know that health did magnificently was a real focus on vaccination.
Yeah.
And I think what we heard was there was this light in Midland that nobody knew about. So in terms of how you actually mobilised people to go into people's homes, we're in a COVID pandemic. We're meant to stay home to keep everyone safe and well. How did that work?
So I guess it was back to the Indigo team. They're amazing. So we did a lot of work in terms of preparing them around risk and making sure that people were safe. But essentially, the COVID vaccination team would go out. We might go out in separate vehicles, for example, where we historically may have gone in one car. Quite often the properties we were visiting required like a police presence as well. And I need to say they did exceedingly well in keeping their distance. So they might stay around the corner. And then we also would coordinate, I guess, that outreach activity with health. So that was through the local vaccination clinic in Midland. But it was obviously a lot of planning, a lot of preparation. Our team are really quite accustomed to working in high-risk environments, and I think that was helpful as well.
Thanks, Sharon. So we've just heard from a fabulous service provider out in Midland. Now, Matt, you're at St Vincent's Hospital. I imagine that's in inner city Sydney. And for those that know I've got a broken shoulder, I went to St Vincent's in Melbourne, and I can't praise St Vincent's Hospital enough for helping me get back on my feet. So, Matt, what are your reflections in the way that health kind of responded to the population of people experiencing homelessness during the COVID period?
Yeah, thank you, Michelle. I'd just like to acknowledge that I'm calling in today from Gadigal land of the Great Eora Nation on the shores of Sydney Harbour, and I'd also like to pay my respects to Elders past, present, and emerging, and any of our First Nations people here on the call today. Just for a bit of context, the Homeless Health Service here within St Vincent's Hospital, we have varying different teams. We're primary healthcare providers. We provide street outreach and clinic-based services to people experiencing or at risk of homelessness. We also have elements of care coordination, and we have some residential services here on site as well that we work very closely with different agencies and different teams, NGOs and health alike. I guess our experience of COVID was probably a little bit different to what you would have had in WA. We sort of didn't have the opportunity to sort of, reflect and plan. We were sort of hit quite early on. So in the Delta wave, early March, it was declared, there was a global pandemic, and then not long after that, the international borders were closed. And around the same time, the Ruby Princess, which was a ship docked in Sydney Harbour, and there was a lot of people who were COVID positive on that ship. We sort of sprung into action pretty quickly. I guess one of the differentiating factors is that for us over here in Sydney, I'll talk about the Sydney experience as opposed to the broader New South Wales experience. We already had a lot of formalised partnerships with our government and non-government agencies. So we work very closely with our Department of Community Justice here, with the City of Sydney, who have got a homelessness unit that do great things out of there, with the Central and Eastern Sydney Primary Health Network, and certainly with the other two LHDs that sort of, the span of the inner city. So that's Sydney Local Health District and South Eastern. We formalised basically a strategy in 2020 prior to COVID. It's called the Intersectoral Homelessness Health Strategy. And from that, we all have different initiatives that we will take carriage of moving forward out of that document. So we kind of had a formalised structure that we could leverage off each other's services. So very quickly, the Department of Community Justice over here initiated a rough sleeping task force with all the sector partners. And what was really pivotal to the success of the task force was that the people who were there in the room representing the different agencies, had authority to basically act and implement anything that sort of came up through that meeting, without having to go through the bureaucracy of emails and phone calls and all that sort of stuff. So that was initiated pretty early on, and that still goes on to this day. Obviously, it's not weekly anymore, but we still meet once a month or once every 2 months. The sector did sort of really respond quite rapidly. A lot of those sort of larger housing, a lot of those boarding houses, deconcentrated a lot of their residents, and we were able to apply for out of guidelines temporary accommodation that the Department of Community Justice had initiated pretty rapidly. So we were moving. I think initially it was about 380 single rooms that we were able to move people into, where they could, isolate if required, or comply with any of the other public health measures. I guess we worked through a number of initiatives, But I will say that, you know, our street-based outreach and our care coordination year on year during that time frame increased by about 270% without any additional resourcing. We were very, very busy. There was a lot of late night meetings, there was a lot of weekend meetings. So yeah, that's kind of our initial experience. We were aware that the borders were all being shut elsewhere, and that would give people time to plan. But unfortunately, we didn't have that.
Thanks, Matt. And as so working within a hospital, how did you work well with the homeless services sector in terms of somebody who may have been rough sleeping and they came to the hospital, and you were aware that they didn't have anywhere to live? How did you optimise their opportunity to get a home and the services, health services or homeless services that they needed?
Yeah, absolutely. So, you know, and that wasn't an uncommon occurrence. If they needed to come into hospital because they were very unwell, obviously that would have been facilitated and they would have received care on one of our COVID wards. In regards to if they weren't so unwell, we moved a lot of clients or consumers into what was affectionately known as the SHA, the Specialist Hospital Accommodation, where people could isolate if they had nowhere else to isolate. That was run through the Sydney Local Health District. Obviously, there was a lot of empty hotels across the CBD that we took up. And when they were in the SHA, we had an opportunity for the teams to go in, work with them. It wasn't only the health teams, but it was the housing teams as well. Go in, work with them, potentially move them back into temporary accommodation, and then with a view to getting them linked into longer term housing options.
So they were dedicated spaces that had sort of latent vacancy accommodation. So you kind of planned for projected people?
Yeah, that's right. There was a lot of planning going on at the time, and you know, one of the big things that we were planning for, and I kind of made it very clear to a lot of my staff that the only way that we were going to get through this was through vaccination. You know, they've made it, the government made it abundantly clear that until we reached a certain target, then the lockdowns would continue. For me, we did a lot of researching and a lot of reflecting on what had worked in the UK and in Canada as well. And from that, I brought a group of health agencies together, both government and non-government, but also the Department of Community Justice, City of Sydney, Nimoy National were a part of those conversations as well. And we did planning for a vaccination hub down in Woolloomooloo, which is not far from where I'm sitting today. We also, it was kind of a three-pronged approach. We wanted to have a hub, we wanted to have some elements of outreach, then there was a social housing piece that we wanted to look at as well, because we knew anecdotally from our colleagues down in Melbourne, there were significant outbreaks within social housing down in Melbourne, and we didn't want that to happen here in Sydney.
Thank you. So, Sharon, if you think back over the last 2 years, what would be a couple of the things that you think we could have done a little bit better? So the vaccination program was amazing, but if you reflect on your time, what were the missed opportunities?
I feel like the missed opportunities are, I guess, were in the planning, and obviously, you know, we've been, I guess it's in WA, this has happened, there was a lot to learn from the eastern states and some of those responses. Yeah, certainly in terms of the coordination, even our own work, that we did a lot in terms of emergency accommodation planning that perhaps wasn't reflected back on. I guess some consideration also to the capacity of the sector, like we were looking after our own staff who were also in the middle of a, you know, kind of pandemic. We employ a really high percentage of Aboriginal First Nations staff, so that also our workforce was quite stressed. And yeah, I guess even just the volume of communication coming was also really challenging to keep pace with and kind of communicate down to the teams and down to the people we support. I feel like we had ample time in terms of a coordinated plan that would obviously support, you know, rough sleepers into accommodation and that partnership with health. So that's what I would like to see, kind of, you know, in terms of preparation. Yeah, I think we had plenty of time.
Thanks. So as I mentioned, we've had three panelists unable to be here today. So I'd like to open it to the floor if anybody's got any questions. We've got a roving mic, I think, with Trish. Are you our roving mic person? And just be conscious of COVID, so you know, don't put the mic too close. But are there any questions people have got? Oh, we've got a Zoom question. Oh my goodness. Okay. So Matt, how are the health needs of people? Oh, you can probably read this, but I'll read it anyway. How are the health needs of people in isolation facilities managed, particularly those with high levels of substance use and complex mental health issues? Thank you, Zoom person.
Yeah, that's a really good question. Obviously, we work with a very trimorbid type model, not only primary health, but we care for people who have significant substance use disorders and significant mental health concerns as well. Within the service itself, we have all of those disciplines. And so if people were moved into temporary accommodation or if they were moved into the specialist homelessness accommodation, all three disciplines would go out and we would make sure that all of their health needs were met, even to the fact where we would, you know, drop off any sort of methadone or any other medications that were required on a daily basis. And hence, you know, you can understand we were significantly very busy during that time. So yeah, I hope that answers your question. We took a broad systems approach, and it was all disciplines. It wasn't just primary health.
Thanks, Matt. And I know that was one of the critical issues here in WA when we had people put in accommodation and then having their acute and bespoke health needs responded to was sometimes a bit of a challenge, to the point where I know we had to get advice from the chief pharmacist here in WA on whether services could administer Panadol to people in isolation. So do we have any other questions from the floor in terms of Matt or Sharon? It's going to be a very short session if we don't have any further questions. No, John? Oh yeah, we do. Jonathan, welcome, Jonathan. The mic's coming your way. Thank you.
Good morning. I just wondering in regards to the actual rollout for understanding that we actually had a problem with street presence. What are we going to do next time that if this does happen again, how are we going to determine with futuristic understanding that the street people need looked after straight away?
Great question. So I might ask you, Sharon, first, and then Matt, reflect on your thoughts from Sydney.
And certainly, how do we know that they're going to be looked after straight away? I feel like there was ample, even if we're looking at the by name list and we're tracking people who may be, you know, vulnerable, I think that would have been a great place to start. And I think also just kind of streamlining the communication. Like the first person that presented to us that was potentially COVID positive came to our resource centre. Having the police COVID response was the line of communication we were advised to take, and that person was arrested. So it was just, you know, like not a good experience at all. I feel like then even the process in terms of accessing help and accommodation, that kept consistently changing. So that was really challenging for staff as well, in that everyone was just, you know, in a sense of chaos themselves, not knowing how to access help. So all of those simple things really just could be streamlined, I think, moving forward. There's certainly some lessons learned, I think, through what's gone wrong.
Thanks, Sharon. And Matt, your reflections on how we don't have any chaos if there were another pandemic?
Yeah, look, I think one of the big things that we kind of tried to quash quite early was a lot of the rumours that were coming out of the sector. There was a lot of mixed messaging, and you know, we were able to put in a document that we could send out to any of the sector about there's one source of truth, and that's coming out of our State Health Emergency Operations Centre. That was something that we kind of learned because it was causing a lot of angst and a lot of confusion amongst the homelessness, the broader homelessness sector. But as a government agency, so working from health, that we kind of put messaging out there that don't listen to any of this stuff. If it comes from us, take that as the source of truth. But yeah, try and limit the chaos of the rumours.
Thanks, Matt. And I know David Pearson, the newly appointed EO of the WA Alliance to End Homelessness and the EO of the Australian Alliance, would like to make a comment. So over to you, David.
Yeah, thanks, Michelle. I've just been listening. I thought it'd be useful to share something relevant to a lot of the conversations here is that there's not a lot of advocacy that happens to the Commonwealth government about how integrated health and homelessness is. And so one of the things that we've done is set up a National Health, Housing and Homelessness Alliance, which was which was a sort of idea that's been pioneered in Canada. And they've been doing a bunch of work, that sort of national network in Canada about, how do we prepare for the next pandemic? How do we learn? And there hasn't been a lot of those kind of conversations in Australia. But that is one of the reasons why we've set this network up. So it has it sort of, it meets sort of quarterly. We've got a meeting next week. So anyone who's interested in the health, housing and homelessness field, and it's kind of got two functions. One is about supporting advocacy at federal government level particularly. But two, also just about supporting practice and learning lessons and sharing that at a sort of more operational level. So there's more information about the Health, Housing and Homelessness Network on the national website, but we have called, one of many of the things we've called for in terms of the advocacy is the development of a health equity policy in relation to homelessness by the Commonwealth government, so that it does grapple with some of these things, because homelessness was very much an afterthought into much of the sort of pandemic planning at different government levels, but it kind of got there in the end, but in some places anyway. But the lessons haven't been sort of institutionalised, and how do we make sure those lessons are learned and those sorts of things. And we think the need for a national policy on that's important. But it also helps us grapple with some of the other things that some people may be familiar with, that just the absurdity of if you're a GP and you want to bill Medicare for providing a service to someone who's experiencing homelessness, you can't do it unless they come to you, or unless you do it as a telehealth consult. So you have to phone a person with a lived experience on the street in order to be able to bill Medicare for that, or face the risk of getting audited for it. And that applies to GPs, nurse health practitioners, mental health nurses, all of the different places that the Commonwealth can pay for health services that people who are experiencing homelessness need, are currently excluded because they don't have anyway. So that the need for that advocacy is there. I just thought I'd make that comment, given a couple of other speakers have disappeared or couldn't be here.
That's great, David. So we'll make sure that there's a link to what he's referred to. And also we do know that the state government's doing a lessons learned, and there'll be an opportunity for the sector to reflect on what worked well and what didn't work well, and have some input into that. So we've got a question from Deborah. Over to you, Deborah. And I think our roving mic is roving its way over to you.
Hi, my question is, and Sharon, because I work a lot in Midland in doing all the ER and logistics, particularly around food, emergency relief, and partner with Midland Meals, and they feed people on the streets 7 nights a week. And what we have noticed is there were quite a few people who were unfortunately struggling directly on the streets with COVID, and released from hospital, not wearing masks, not wanting to stay in hospital, although the advice was that they should. One particular one we were really concerned about, because he had really, really sick. We were worried he was developing pneumonia, but there was nothing really else we could do. So the frustration is, one, no masks, and two, just needing so much support. So I'm not sure, and also for person representing medical area, what could be done to improve this? Because one, of infection of others around, but particularly just the concern that this could lead to death on the street from COVID. So how can we support people in that situation, because he was uncomfortable being in the hospital? What can we do?
Yeah, certainly. I mean, we distributed literally thousands of masks and RAT tests through the Community Resource Centre. And I think part of it is about that education. You're dealing with people with a range of different issues going on. That might be, you know, in terms of complex mental health. And yeah, it's not just that straightforward in terms of encouraging people to wear masks. Certainly what we found challenging, and I understand has been recently resolved in some degree, is around trying to access accommodation for people. So in that set of circumstances, we may get short-term or, you know, budget hotel accommodation for somebody that might need it. Quite often, particularly our local providers of that kind of accommodation can be burnt out because of issues around behaviour and risk that then, I guess, for our local caravan park, for example, may not be willing to accept people that have been at the accommodation service before. So that's presented issues. Yeah, I understand that Bart's has been funded some short-term accommodation, which is essentially in terms of those lessons learned. You know, that's exactly the kind of response that we needed, you know, back then. And it's welcomed now, certainly.
Thanks, Sharon. And Matt, what did you do in Sydney when you had that circumstance arise?
Yeah, thank you. Thanks for the question. Look, we acknowledge that there's all levels of health literacy out there for any of our clients or our consumers. Look, we would try and use less restrictive measures whenever we could. This happened probably on a number of occasions. I can't think off the top of my head, but it'd be less than 5, where people would be exited from hospital into homelessness, who were COVID positive. One of the things that we can do, which is a much more restrictive practice and that you don't want to have to initiate if you can get away with it, is the public health units can put people under a public health order, and therefore they're mandated under the laws of New South Wales Health that they have to remain within a hospital or wherever they're receiving care. As I said, that's a very restrictive practice, but we did initiate that on probably 3 or 4 occasions throughout the course of the last 2 years. Obviously, we want to go down the less restrictive practice route. We want people to, you know, diversional therapy, sending a lot of, asking them whatever they needed, blowing my budgets on certain, food items or whatever to try and keep people within hospital. But yeah, the less restrictive is the best way to go. But on a number of occasions, we did have to sort of restrict people's movements through an order.
Thanks, Matt, and great question, Deborah. So I might just share with you, Shelter's been really fortunate to receive 2 grants. So we've received funding from Lot 3 West, and we've put on an infection control nurse, Elizabeth Brown, who's just walked through the door. So that's serendipitous. So for the next 12 months, we'll be working really closely with our members to support them develop really robust infection control plans. A lot of our members aren't clinical. And so that will be really helpful in terms of Elizabeth being a registered nurse, going out, doing a bit of an audit, seeing what's fit for purpose in terms of infection control practice. And the other thing is we've just received a significant amount of money from the Department of Health to support our sector to rapidly purchase accommodation, health support, food, etc. We're rapidly building a website at the moment, and we've just put on a project officer who starts on Wednesday, and so that will be a reimbursement scheme. So somebody like Sharon can do what she does well, and based on those guidelines, she can then say, this is what I spent, staff time, accommodation, food, medicine, whatever, and then through this reimbursement scheme, we'll just, no questions asked, reimburse Sharon if it meets the guidelines. So we hope to have that reimbursement scheme up and running, and that will be retrospective. So any service from the 1st of June that has supported somebody who's COVID positive within the homeless population will get reimbursed, because we did hear from the sector that was a real challenge. So 2 fabulous partnerships with government that we will be progressing shortly. So do we have any further questions from people regarding the COVID situation? Great question from Jonathan, great question from Deborah. Do you have another one, Mr. Shapiro? Okay, over to you.
As far as using existing facilities, that's one of the things that I've found a little bit hard to understand. We have some great immigration detention centres that are actually not being used. One in South Australia outside Whyalla, I think, I'm not too sure, it houses about 150. There's 2 in Perth. They're sitting there with absolutely nothing to do, no one doing. Why can we not, and why have we not utilised such facilities that we've already got in place that would put up people? All you got to do is put a bus to them, get them there, and then put nurses and everything, facilities going to get it going.
So that's a question for you, Sharon, I think.
Yeah, certainly we progressed that conversation with the City of Swan in that one of those facilities is located in Bullsbrook, which is an ideal community, even part of the facility. I think it had been established with the capacity for 700, but we certainly didn't have the necessity for 700 beds, but it was certainly set up, and we definitely progressed that discussion with City of Swan, and the outcome is still pending.
Yeah, so I think also just speaking to the services, the challenge is staffing. So in terms of once you've got somewhere for people to stay, having the staff support, the health support, and making sure people are well was a real challenge as services got COVID, staff got COVID, etc. But Jonathan, there is a lessons learned, and I think they're the sorts of things we need to capture as part of the lessons learned process moving forward. And it's fabulous having Gail here from the Department of Communities. And I know that we've got a commitment from communities that the sector will be involved, and they're generally really great in engaging with us. So we look forward to capturing things. So do we have any further questions on Zoom? No? Okay. So what I might do is give the gift of time back. So if you could give a big round of applause to Sharon for joining us, and to our fabulous state speaker from New South Wales, to Matt. Thank you so much for your time, Matt. And I just want to acknowledge that it was a really tough 2 years, and that the ability to work in partnership with SHIC and SWIC was just critical. We're all scrambling, trying to make things happen as they unfolded, and we got some things wrong, we got some things incredibly right, and this lessons learned is just going to be magnificent in terms of future-proofing us, hopefully, if we get another pandemic come our way. And certainly once we have these 2 new programs up and running, which will be done rapidly, we look forward to supporting our sector